you know, before you even do
Mm-hmm.
something. So it's small,
Yes,
small,
ma'am.
small, small. I'm sending live so that I would not have to record it.
Have to do it later.
My
Yes, ma'am. That's
laptop's
perfect.
memory is full and
No, ma'am, it's all
it
right. This
becomes
is the
really
perfect
hectic.
thing.
So
I think you should have started this before, ma'am. This is absolutely a
no, we
great
were chit chatting.
step. No, no,
Now
no.
now
All right, ma'am.
before we were talking. Okay, if you're ready, I'm starting the timer.
Yes, ma'am.
Okay, started the timer. You'll be given 1 minute, and here is your question. Right? If you have read and understood, kindly tell me what is your provisional diagnosis?
Ma'am, my professional diagnosis is this patient is suffering from multiple endocrine neoplasia type 1.
Okay. How did you come to know that? What are the signs and symptoms?
Ma'am, multiple endocrine neoplasia type 1 is a syndrome which consists of hyperparathyroidism. The patient has gradual worsening of epigastric pain with nausea, vomiting, and diarrhea. That means there are features of lipoma, which means that there is a pancreatic lesion, and all which is confirmed by a contrast CT scan that shows there is a hyper-enhancing pancreatic lesion. That means there is a pancreatic tumor. Because the patient has diarrhea, perhaps it is a lipoma, and also the patient might have a pituitary tumor associated too. So these all features mean that the patient might be suffering from MEN1.
If you do the pathology of this patient, then what will be the microscopic features that you will come across?
Ma'am, on microscopic slide, we'll see parathyroid hyperplasia, which there will be
Yes.
multiple oxyphil cells and multiple, sorry, not oxyphil, multiple chief cells will be there, and there will be islets of oxyphil cells, and sometimes there is also hyperplasia of the water clear cells.
Can you tell me how many pituitary glands can get infected or affected in this
Uh,
case?
the patient is suffering from parathyroid hyperplasia, which will involve all the four glands of parathyroid, all four parathyroid glands.
Why the patient presents with hypoglycemia?
The patient might
What
have
might be the cause?
associated. The pancreatic lesion could mean that there is also insulinoma, so that is why the patient is developing hypoglycemia.
And this will be derived from which cells of pancreas?
Insulinoma occurs due to a tumor in the beta cells of islets of Langerhans of the pancreas.
Why patient with hypoglycemia becomes unresponsive?
There
You
are
syndrome.
multiple causes. Unresponsive hypoglycemia may be due to nesidioblastosis, maybe inherited glycogenesis, maybe ectopic insulin secretion from certain tumors such as a retroperitoneal fibrosarcoma or fibroma, or it may be due to abnormal insulin sensitivity or even altered liver diseases. Abnormal liver
Can you
diseases, yeah.
can you name some other conditions that also present with hypoglycemia?
And nesidioblastosis, then Addison's disease,
Yes.
and yeah, and insulinoma itself.
Okay. Can you tell me the clinical picture of insulinoma? How would you
The clinical
diagnose? the patient?
Diagnosis of insulinoma is by the Whipple's triad, which means that the patient will present with clinical features of confusion stupor coma with a blood glucose level of less than or equal to 2.5 millimole per liter, which occurs due to either fasting or exercise, and is usually relieved by taking oral or parenteral administration of glucose.
Good. Can you please tell me in pituitary how would you differentiate MEN 1 syndrome from MEN 2 syndrome?
MEN 1 syndrome patient usually presents with a parathyroid hyperplasia or parathyroid adenoma and a pituitary tumor, as well as a pancreatic tumor. MEN type 2, there is two type 2A and 2B. 2A presents with parathyroid hyperplasia with pheochromocytoma with medullary carcinoma of the thyroid gland. And MEN 2B, along with the features of MEN 2A, there is also marfanoid features and mucosal neuromas. And
Good. Can you please
then
tell me?
the
Yes.
MEN
Yes.
1A occurs usually due to a mutation in the menin gene on chromosome 11, whereas MEN 2A and B occurs due to a mutation in the red gene on chromosome 10.
Can you define the term gene?
Gene is defined as a sequence of nucleotide present on a DNA or part of a DNA which encodes for a particular protein, and that is expressed phenotypically later on.
What is telomere?
Telomere is a repeated sequence of nucleotide present on the ends of the chromosomes, which has various functions. Of one is which usually keeps the chromosome from deterioration and also from fusion with the adjacent chromosome. And this telomere usually is the sequence, nucleic acid sequence tag double T, A, and triple G.
Good. Can you please tell me 3 genes mutations which are seen in case of insulinoma?
There is the menin gene, which occurs on chromosome 11. Then
Yes.
there is the TSC. Then there is the tumor suppressor gene, which occurs in cases of P10 and TSC2. And there is also the other two genes are alpha thalassemia. Mental retardation syndrome, and also a death domain associated protein. These two fusion genes, and when there is mutation to these, there is usually problems in the telomere maintenance.
Okay, good. Can you please tell me what is associated with MEN 2 syndrome? What are the features?
MEN 2 syndrome there is pheochromocytoma, a medullary carcinoma of
Oncogenes.
the thyroid.
Yes, yes.
Oh, oncogenes. With the two is the P10 gene and the tumor suppressor genes. The tumor suppressor genes like the P10 genes.
Rec proto-oncogene.
Oh, red.
Okay.
Okay, ma'am.
Yeah. Okay, can you please tell me what would you like to exclude before you will go ahead with the patient for go ahead with the operation? So, like in case of patient
With
mental.
in that case, ma'am, we'll have to exclude if the patient is having any pheochromocytoma.
Yes, good. So,
And
okay,
also,
yeah.
yes, ma'am.
So, medullary thyroid carcinoma, it contains stains for calcitonin, and
Yes, ma'am.
if you do the pathology report, what would it show?
Pathology of the medullary carcinoma of the thyroid will show that there is activation of the parafollicular C cell. Parafollicular C cells in the thyroid glands will become activated and will produce calcitonin.
Good. What blood test and urine test can be done to rule out pheochromocytoma?
Blood test will do, urine test we can do the urinary vanillin mandelic acid test, and in the blood we can do the circulating catecholamine, circulating metanephrines, and also we can do the catecholamine stimulation test.
Good. Okay, right. Can you, name 5 carcinomas that can classically metastasize to bone?
It could be a renal cell carcinoma, a follicular carcinoma of the thyroid glands, then a breast carcinoma, a lung adenocarcinoma, and also the prostate carcinoma.
Good. Okay. Yes. Good. Thank you.
Thank you, ma'am.
There are 2 hypotheses in this case. If you in this station, if you can
Two-hit
tell
hypothesis,
or
ma'am.
discuss. Yes.
Okay, ma'am. So it is called the Knudson's two-hit hypothesis, which actually means that if there is any mutation in a tumor suppressor gene, for it to be expressed, for the cancer to be expressed, it has to be in the recessive form, and it has to be obtained from both the alleles, as in from both the sets of parents. The genes should come from the mutated genes should be there in both the sets of parents. In that case, considering these lines, in case of men, there is two-hit hypothesis occurs. The first hit occurs in the germline mutation. That means there is the defective gene is inherited either from one parent in cases of a familial case, or there may be a defect or a mutation during the embryonic development. That would be in case of a sporadic case. Then this is the first hit hypothesis. The second hit will occur in the somatic cells, which ultimately these two together will give the features of the Men syndrome. This is called the Knudson's two-hit hypothesis.
Superb. Very good. Excellent. Thank you so much.
Thank you, ma'am.
Thank you. Right. Anyone else would want to go? Dr. Mohammed, your station is for tomorrow, right?
Yes, tomorrow, inshallah.
Yeah, inshallah. So, if anyone would like to go today, anyone else? If not, then we have second station. Yeah, she does, doesn't she? She inspires everyone. Yes. Very good. That's how I want. No, okay. Now I'm sending live. I'll not say it. I'll tell you afterwards. Okay. So if no one else is ready, then we'll have second station of Dr. Ulfat. So this is good when people say they will do 2 stations. Then I can just do 2 stations and I can have my day off. Yes, Dr. Ulfat, you want to
Yes,
drink
ma'am.
some water or go ahead with the second one?
Ma'am, I wanted the examination, and but
Yes,
ma'am,
it is
I have.
examination.
It is examination, ma'am. Ma'am, if you could tell me what you've prepared, because I am not sure I
Now
can do
I'm
the
sending
examination
live.
today.
Okay,
All right,
then we'll
ma'am.
not do it. We'll
If you
just
could
we'll
do,
just end it
if
here.
you have, ma'am, but I can go for a communication skill examination or a history taking if you ask me, ma'am. I can do that.
But then I need someone else to help you with as well.
No.
So I all the other members
Yes.
are new, so we can
Oh,
do
okay,
that
okay.
tomorrow. Yeah.
Yes, ma'am. Yes, ma'am. Uh, all right, ma'am. Then I think I'm so sorry, ma'am. I thought I could be able to
That's
do
okay.
it
No
today.
need to say sorry. No, absolutely not. No need. It's just that I thought, okay, I'll bring one because you didn't say which examination, so
Ma'am,
I
which
just got one
examination did you
random.
prepare for me?
Abdominal.
Oh, okay, ma'am. I think I can go for it. Ma'am, let's just try. Let's see, ma'am. I can, inshallah.
Sure?
It's an abdominal. Inshallah, ma'am. Let's go.
Yeah, it's abdomen, so I think you can.
Inshallah, ma'am. Yes, ma'am.
Okay, ready?
Yes, ma'am.
All right, I'm starting the timer, and here is your question.
Okay, ma'am.
Right, if you have read and understood, kindly begin your examination session.
So I'm going to enter the examination hall. I'm going to wash my hands and I'm going to introduce myself, and then I'm going to confirm the patient's identity by name and date of birth. Then I'm going to explain to the patient that I've been asked to examine the patient's abdomen, and this would include tummy. This would include me looking at the abdomen and taking a whole examination of her overall status, health status, and also listening to her tummy, as well as performing some procedure tests over them if she's all right. After that, after she has consented, I'm going to now ask the patient to expose, and here I'm going to ask the patient if she requires. Then over here, I'm going to expose the patient from the mid chest to mid thigh, and and also I'm going to ask her to remove her innerwears. I'm going to ask if she requires a chaperone. Then I'm going to start my examination. First, I'm going to take an overall a general examination from overall look of the patient's health status, and if there is any obvious wasting, or if there is any obvious swelling anywhere else. Then I'm going to check her anemia on the lower palpebral conjunctiva. Then I'm going to check her jaundice in the sclera. Then I'm going to ask the patient to show her tongue to exclude dehydration, to exclude anemia, and also the ventral surface of the tongue to exclude jaundice. Then I'm going to check her nails to exclude if there is any clubbing or any colonychia, leukonychia. Then I'm going to check her chest to exclude if there is any spider nevi, if there is any rashes, and then I'm going to check her abdomen. Now I'm going to start, and I'm also going to check her supraclavicular region to exclude if there is any lymphadenopathy. And then I'm going to go to her abdominal examination. Here I'm going to start with inspection. I'm going to start first from the top to see the shape of the side and the shape of the abdomen, to see if there is any scar marks, if there is any swelling, any obvious swelling. Then I'm going to ask the patient to lift without lifting her legs or her abdomen, just to lift her head to see if there is any swelling that becomes prominent. Then I'm going to see if there is any scar marks, or if there is any rashes, if there is any caput medusae. Then I'm going to tell the patient, does she have any pain? If not, then I'm going to start palpating with the palm of my hand the whole all 9 quadrants of the abdomen, and then I'm going to start with deep palpation. And then after I do the 9 quadrants deep palpation, I'm going to do the palpation of the liver with the radial border of my fingers. Then I'm going to do the palpation of the spleen and while I'm done with the palpation of the liver, I'm going to also percuss the upper border of the liver dullness. Then I'm going to do the spleen with the tip of my fingers, and I'm going to continue. I'm going to do the spleen, and then I'm going to again percuss over the spleen. Then I'm going to manually ballot both the kidneys, and then I'm going to check the suprapubic area. Now I'm going to start examination of the swelling. I'm going to ask the patient to again lift their head, and then I'm going to see whether the swelling becomes more prominent. And then I'm going to see over the swelling. I'm going to measure the size of the swelling, to check the surface of the swelling to the margin of the swelling, and then also I'm going to see if it is stuck to the underlying structure of the overlying, and do the pinch test to see if there is overlying stuck to the overlying skin. Then I'm going to do the trans-illumination test. Here I'm going to ask my examiner to dim the lights. I'm going to take a cone of light and see if there is if the swelling trans-illuminates. Then I'm going to place my hands and try to press the swelling down, and remove my hands to see if the swelling is compressible or not. Then I'm going to check and while I'm doing all this, I'm going to look at the patient's face to see if there is any change of expression to exclude tenderness of the swelling. And then I'm going to measure the swelling with a tape, and then after that I'm going to see if there is After this, I'm going to do the percussion. I'm going to do the percussion of the whole of the abdomen and to exclude if there is any fluid, then exclude if there is any shifting dullness. If I find a shifting dullness, then I'll do a fluid thrill. After that, I'm going to auscultate it. First, I'll auscultate over the swelling to see if there is any bruit. Then I'm going to auscultate at the left ali fossa to check the bowel sounds. Then I'm going to do the auscultate if there is any hepatic bruit, if there is renal bruit, and the aortic and if there's any aortic bruit. This concludes my examination. After to conclude my examination, I would like to check the other hernial orifices are intact or not. I would like to do a digital rectal examination. I would like to do an examination of the external genitalia and also the examination of the lower limbs. Then I will ask the patient to redress. I will wash my hands and thank the patient.
Okay, can you summarize your case now?
I have just examined a 54-year-old female who has presented in the surgical outdoor with a swelling in the peri-umbilical region. The swelling is about 3 to 5 centimeter in diameter and becomes prominent on cuffing and straining. And the patient and the swelling is slightly tender and it is reducible, and it is not transilluminate, and it is well defined, and is not stuck to the underlying structure, not stuck to the overlying skin, and there is no bruit over the swelling. So, and all the other hernial orifices are intact, and my diagnosis
So what
this
is
could
your
be a
PS?
peri-umbilical hernia.
Okay. How would you manage this patient further?
After thorough clinical examination and also appropriate history taking, I would like to do some investigations. Investigation would be I would do an ultrasonography of the whole abdomen, and if the findings are not conclusive, I would go for a CT scan of the abdomen, provided her renal functions are intact. And management of this patient would follow either open or laparoscopic repair of the hernia.
Okay. How would you or would you not place the mesh?
Ma'am, I would place the mesh for this.
Okay.
And here,
What are
mesh
the
can be played.
different procedures? Yes.
Ma'am, mesh can be played onlay mesh inlay. If we go for open mesh repair, then
Yes.
it can be either onlay, it can be inlay. Onlay is above the just below the subcutaneous layer. Then if it is inlay within the layers of the muscle, then if it is sublay below the layer of muscle, and then there is another which is the intraperitoneal onlay mesh repair.
Okay, and if it's
Just
done
above the peritoneum.
laparoscopic, then how mesh is placed?
Then laparoscopic mesh repair, ma'am. It will be ma'am only, ma'am.
Okay. Did you thank you so much, Pele, for when you were explaining to me, did you tell me the size of the lump
Yes, ma'am.
in
Side.
centimeters?
Yes, ma'am. 3 into 5 centimeter. I said, ma'am.
Okay,
Just
I'm
a
sorry, I
random.
didn't. I thought you did, but I wasn't sure. I missed, I think.
But ma'am, I
From
know what
asking
I
you.
missed, ma'am. I know after I saw the question, I missed the cough reflex. I forgot to ask the patient to cough.
Yes, because
Ma'am,
that
I'm
was
so sorry.
hernia.
Yes, ma'am.
That's okay.
I did everything. I did
That's
the.
why we do revision practice.
Yes, ma'am. Yes, ma'am.
Good. Thank you.
Thank you, ma'am.
Anyone else want to go? Want to try station? Or we can just stop the sending. Yes.